Everyone. My name is Laila Nomani, and I'm a cytopathologist at the Medical College of Wisconsin. I did my medical school in India, and after that, I did my residency at Cleveland Clinic in APCP, followed by a hematopathology fellowship at Cleveland and a cytopathology fellowship at Loyola University Health Center. Subsequent to that, I am now practicing as a cytopathologist and working as an assistant professor at the Medical College of Wisconsin. I'm really grateful to the American Society of Cytopathology for giving me this opportunity to talk about a pattern-based approach to lymph node cytology. So let's begin. I'll briefly go over the outline of the things I'm intending to talk about today. First of all, we look at the role of lymph node FNA. What are the advantages? What are the limitations? We will then identify some key patterns that are usually encountered on a lymph node cytopathology specimen. We'll then look at some case-based examples highlighting the different cases that we can see. And we'll finally wrap up with the future trends and what the role of standardization would look like for lymph node cytopathology. So lymph nodes are one of the commonest specimens that are either FNA'd or biopsied. And this technique has actually been around for more than a century now. And one of the most common reasons that a lymph node is FNA'd is because it is simply enlarged. An enlarged lymph node can be seen in pediatric patients, it can be seen in adult patients, and this finding is usually what prompts the clinician going for a diagnostic modality. Most common pathology that we usually see in enlarged lymph node is either a reactive hyperplasia, it can be some kind of infectious or inflammatory reasons, or most commonly some metastatic malignancies, as well as involvement by lymphomas and leukemias. The enlarged lymph node that is biopsied can either be superficial or they can be deep. Increasingly nowadays, we have these imaging modalities like EBUS and EUSs, which are used to sample these. In combination with rapid on-site assessment, this is actually an excellent technique for triaging specimens. So it is safe, it's minimally invasive, and usually has a quick turnaround time. As already talked, it is well established. It is used increasingly both in developing as well as developed countries for FNA for the initial diagnosis of any lymph node pathology. It is good to get a sample at rapid on-site assessment and know that it is adequate so that subsequent workup can be done. Many studies attest to the high sensitivity of this technique for determining the diagnosis of lymphoma versus no lymphoma. Also, in cases of metastatic tumor, the diagnostic accuracy is almost a 90%, and the positive predictive value is around 100%. The other advantages are that it can rapidly give us a diagnosis of benign versus malignant. Of course, there are cases in which it is challenging to even make that distinction, and we'll see once we go over our cases how we can go about approaching those. For samples which are predominantly show granulomas or show cytomorphologic features that would point towards an infectious etiology, that is also helpful to know, to let the clinician know on site so that appropriate material can be taken for the microbiology studies or serology studies as needed. For lymphomas that have already been diagnosed, FNA can provide a useful technique for documenting the recurrence, the persistence, and the progression of lymphomas. And as already noted, this is excellent for getting material for ancillary studies, whether they be for flow cytometry, for research purposes, or as prognostic or predictive markers. As with any diagnostic modality, there are limitations. So one of the main limitations is that there is a lot of morphologic overlap between various benign reactive conditions that we see in the lymph node, which include hyperplasias, and these can mimic low-grade lymphomas. So there is a lot of cytomorphological overlap between these. And usually FNA by itself, just on cytomorphology, is difficult to accurately classify what is going on. In case we have a predominantly necrotic specimen, again, the cytomorphology is not readily appreciable, so that would be another limitation. For diagnosis of primary lymphomas and classification, just FNA by itself is not enough. One of the limitations is that the architecture cannot be assessed. And in some cases where there is either partial involvement or if you have in situ lymphomas, those can be notoriously hard to do on just cytomorphology. Another limitation are the Hodgkin lymphomas and the Hodgkin-like lymphomas or its mimics, in which usually the lymph node can be fibrotic, so it might be difficult to actually aspirate it. There you can have like the neoplastic cells can be scanned, or they can be like paucicellular. So in that case also it will be difficult to get a good sample or to do the immunostains to determine what is going on. And many of these Hodgkin and Hodgkin-like conditions actually need an architectural assessment. So these are some of the limitations that we can encounter. Moving on, here what I show is the WHO, the current WHO classification of tumors of the hematopoietic and the lymphoid system. This is the 2017 latest edition. And as you can see, this page, these two pages just show the B-cell lymphomas and the classification of T-cell lymphomas. So you can see that there is a mind-boggling number of entities that are now in the current WHO. And anybody would be really surprised and shocked at the number of entities that we have, and would actually not be very comfortable diagnosing them without having an in-depth knowledge of these entities. This is a flowchart which shows how I usually like to approach my lymph node sample or a biopsy that I'm asked to do touch preps on. So if we see here, I have you start with the touch preps or the smears and the rapid on-site assessment. The first important thing is to assess whether the sample actually represents the site that is being sampled. So if the clinician is sampling a lymph node, we expect that on our slide we will see lymphoid cells. In many cases, when they are doing EBUSs, sometimes all we see are benign bronchial cells and no lymphoid cells. In that case, what we need to make sure is that we communicate that this sample is inadequate and ask them for more passes so that we can get an adequate lymphoid specimen. In some cases, when we do not have a predominantly lymphoid sample, but we see atypical cells or malignant cells, in that case, we can call the sample adequate, ask for a cell block to do our ancillary studies on. The other thing would be when your sample is predominantly lymphoid. When the sample is predominantly lymphoid, the question arises whether we think it is just a benign lymph node or is it something malignant. And sometimes, quite often actually, we might not be sure that what is going on in the lymph node. It is very important in such cases to know what the clinical picture is, because the clinical picture and the clinical suspicion determines the extra knowledge that we have to determine what we are looking at is actually adequate or not. So if the clinical suspicion is low and what we see is a very polymorphic pattern, and we are confident that the cytomorphologic features most likely resemble a benign reactive condition, we can confidently go ahead and call it negative for malignancy and not ask for a flow cytometry, but get an appropriate cell block. If we see granulomas or anything that would point us towards an infectious etiologies, it is important to get serology and microbiology studies. Again, if we are not sure and we don't know whether it is malignant, whether it is benign, the clinical suspicion is kind of intermediate, or the clinical suspicion is low, but what we see is more revved up than what we would usually see in a lymph node, get a flow cytometry specimen. that would be really helpful in addition to the cell block. And depending on how high or what the clinical suspicion is, a core biopsy may also be asked for. When we see a clearly malignant lymphoid sample, in that case, flow cytometry, a cell block, a core biopsy, and making sure that we have adequate material for FISH, for molecular studies, for any gene rearrangement studies, that would be essential. So this is just a simplistic diagram. Moving on, this is what are the main patterns that you would usually see on a lymph node cytopathology preparation. Excuse me. So this I have taken from the book Lymph Node Cytopathology by Drs. Pambushin and Bardale. And I really like this depiction of the main patterns that we see. So first, there is the polymorphous pattern in which you can have a mixture of small lymphocytes, intermediate small size lymphocytes, and large lymphocytes. Then we have the predominantly monotonous patterns in which you can have a predominantly monotonous small cell pattern, an intermediate cell pattern, and a monotonous large cell pattern. So if we look at the monotonous patterns, it is basically which cell type predominates. You can always still have some smaller lymphocytes mixed in with the large cells, but what we are looking at is essentially what is the predominant cell type. And lastly, we have the pleomorphic pattern. For the pleomorphic pattern, we have these large scattered pleomorphic cells which may or may not have very prominent nucleoli. And the question there would be, are these lymphoid or are these a carcinoma cells? So now that we know what are some of the main patterns that we can see on a lymph node FNA or a lymph node touch prep, let's just briefly go over the type of lymphocytes based on the size. So we have the small lymphocytes. The small lymphocytes are usually 6 to 12 microns, and they usually are twice the size of an RBC or less than a histiocyte nucleus. We have the large lymphocytes, which are usually greater than 20 microns. They are approximately around 3 times the size of a red blood cell and around 1.5 times the size of a histiocyte nucleus. And then we have the intermediate cells. The intermediate cells are the cells which are kind of in between the small and the large lymphocytes. And sometimes these are the ones that are the hardest on touch prep to accurately classify. Briefly looking at the normal lymph node cytology, so we have the lymphoglandular bodies in the background, which attest to this being a predominantly lymphoid specimen. So important to note here that lymphoglandular bodies are just a testament to the fact that this is a lymphoid sample. It does not give us any additional information regarding whether this is benign or whether this is malignant. The other things that we can see in a reactive lymph node are the tingible body macrophages, usually associated with reactive hyperplasias, but important to remember, these can also be seen in high proliferative or very aggressive lymphomas. The other cells that we see are the lymphocentrocytes, the centroblasts, which are usually larger and have these peripherally placed nuclei, as opposed to an immunoblast, which is also large but usually has a single large nucleolus. Centrocytes are usually smaller. They can be small centrocytes, there can be large centrocytes, but the nucleus is usually irregular or what we call cleaved. And lastly, we can have the dendritic cells. Armed with this knowledge, let us take a look at our first case. So this right here is a 55-year-old male who had an abdominal lymphadenopathy. If we look at the smear at low magnification, we see that it is pretty cellular. There is a mixture of cells, and even at this magnification, it seems that there is something which looks like small vacuoles in the lymph node cytoplasm. Going on higher magnification, we see that there are some bigger lymphocytes, some smaller lymphocytes, and those vacuoles which were we were able to see on low mag are better appreciated on high magnification right over here. These are the red cells in the background and for size comparison. So these are the features that we would usually look at. What was the clinical suspicion in this case? So the clinical suspicion in this case was high. The pattern was mostly polymorphic. There was an equal number of smaller and larger cells. However, the lymphocytes looked very atypical with all these vacuoles and irregularity. So the preliminary diagnosis here was malignant. We did ask for a flow cytometry and a core biopsy. So whenever we encounter a polymorphous pattern, these are the main differentials that should go through our mind. It can be a non-specific lymphoid hyperplasia. We can have infectious lymphadenitis. It can be a follicular lymphoma. It can be a mantle cell lymphoma or nodal marginal zone lymphomas. So any of these could present with a polymorphic picture. For our case, we did send the specimen for flow cytometry, and as you can see, there is a CD20 and a CD19 positive population, which is also lambda monoclonal. This population was CD5 and CD10 negative. I'm sure many of you already know where we are heading with this case. However, before we go, just a little refresher on the differential diagnosis of small B-cell lymphomas and the typical phenotypes that we may see and some of the stains which are newer and help us. So as you can see, all of them are B cells, and you can see that the CD20 is usually bright in all of them except for CLL where the CD20 is dim. So that is an important thing to note when looking at the flow. Usually looking at CD5 is the next step, and as you see, there are two main lymphomas which are CD5 positive. One of them is the B-cell lymphoma, the B-cell small cell lymphoma, or the chronic lymphocytic lymphoma, and the mantle cell lymphoma. So for the mantle cell lymphoma, there are other markers which can help us distinguish it from CLL. And one of them is SOX11 and the other one is cyclin D1. For CLL, we have CD200 and LEF1, which can be helpful in reaching the diagnosis. Looking at marginal zone lymphoma, we usually do not have any marker which is specific for it. So it is usually after excluding all the other small cell lymphomas, we can go towards the diagnosis of marginal zone lymphomas. For follicular lymphomas, those are usually CD10 positive, so they can be easier to diagnose. And then we have lymphoplasmacytic lymphomas, which again usually show an overlap with marginal zone lymphomas. However, the MYD88 mutation can help. So this was our case, and this was the excisional biopsy on it. As you can see, there is a proliferation of these monocytoid small B cells, which are CD20 positive. They are co-expressing BCL2, and here we have the LEF1 immunostain, which, as I already discussed, is usually positive in CLL, but in this case here was negative. So this was a case of marginal zone lymphoma. So for marginal zone lymphomas, we have three main types. We have the nodal, the extranodal, and the splenic marginal zone lymphoma. They are usually negative for CD5, CD10, and BCL6. And they are positive for 1920. They show kappa or lambda restriction, and they can co-express CD43. There are four main translocations seen, which I have just noted over here. And important to remember that 1118, 1418 are usually more commonly seen than 314, which is usually rare. This image here highlights a commonly seen finding on lymph node aspirates. This is a lymphohistiocytic aggregate right here. This image I have taken from ExpertPath because I thought it was excellent to highlight this finding. I recently had a case which was FNA of an enlarged porta hepatis lymph node, and that lymph node was in a patient who had a history of pancreatic adenocarcinoma. The patient was on neoadjuvant chemotherapy, and clinically the clinicians thought that this enlarged lymph node might be a MET. When we did the on-site assessment, I looked at the specimen. I saw many of similar these lymphohistiocytic aggregates like this. There was a polymorphous background of lymphocytes. So I was kind of, this has like, for lymphoma, it had a low clinical suspicion. The pattern was more so like polymorphic. I was more towards benign. However, one thing that stopped me from entirely dismissing it as benign was that the size of the lymph node was significantly enlarged. So I asked for a flow cytometry, and I did not ask for a core biopsy because honestly my suspicion was not that high in this case. Once we got the flow cytometry back, there was a population of B cells that was expressing CD10 and was lambda monoclonal. So this right here was a CD10 positive B cell lymphoma. That is how the flow was reported out. The patient then underwent an excisional biopsy. On the excisional biopsy, as you can see, the architecture of the lymph node is effaced. There are different sized follicles here. These follicles usually were comprised of small centrocytes and few centroblasts. On immunostaining, they were positive for CD20, CD10, and co-expressed BCL2. So this was diagnosed as a follicular lymphoma grade 1-2. An important thing when we are talking about follicular lymphomas is that they are notoriously hard to grade, and it is not even recommended to grade them on just flow cytometry specimens. So accurate grading will need an excisional or a core biopsy in most cases. Moving on to our next case, which is case 2. This was a 66-year-old male with an oral cavity mass. And as we can see, again, a very cellular aspirate. And here the cells are more monotonous looking. I would be saying that these are mostly small to intermediate size, but probably more towards the small size, but very monotonous population. The clinical suspicion here was high that this is involved by some kind of malignant process, not really whether it is lymphoma or is it some other kind of tumor. The pattern here was more monomorphic. The preliminary diagnosis that was malignant. For flow cytometry, yes, we need a sample. For core biopsy, definitely yes. So this is a predominant small cell pattern, which can sometimes also be predominant intermediate cell pattern, and usually seen in reactive hyperplasias, in small lymphocytic lymphoma, in CLL. Again, follicular lymphoma, mantle, marginal, they all can present with this morphology. Another thing to remember are the metastatic small cell malignancies. Looking at the flow from this case, so we had a CD19 and CD5 positive population, which right over here we can see was kappa restricted. So this was the excisional biopsy. As you can see, there is a proliferation of these small irregular lymphocytes, which is completely effacing the architecture of the lymph node. There were these epithelial histiocytes associated with it. On immunostaining, we can see that most of these were CD20 positive. They were co-expressing CD5, cyclin D1, and SOX11. So this was a case of mantle cell lymphoma. Now, mantle cell lymphomas are usually aggressive. However, important to remember that there is an indolent form of mantle cell lymphoma, which is usually characterized by SOX11 negativity. There is a translocation associated with it, which is 1114, which is seen in mantle cell lymphomas. So these lymphomas are usually positive for CD19, CD20, CD5, SOX11, and cyclin D1. Again, left one is a good stain to distinguish this from CLL because it is usually negative in mantle cell lymphomas. They can have, they are usually surface IgG positive and can have IgM with or without IgD. We have to remember about the blastoid variant of mantle cell, which raises diagnostic confusion with lymphoblastic lymphomas with the higher grade, like high-grade B-cell lymphomas. So just remember that there is a blastoid variant of mantle cell as well, which can be easily excluded by simply doing a cyclin D1 stain or a soxylan stain. Moving on, another of the patterns that we can see when we are confronted by a small lymphocyte population is these small cells, which kind of have a chromatin that is called as soccer ball chromatin. We can see this here on the PAP stain as well. And this, I'm sure you all have recognized correctly, the soccer ball chromatin pattern usually points towards a small cell or a CLL SLL. Here we have some smudge cells, or what are known as basket cells, which can be seen in CLL, but can also be seen in a variety of other conditions, which could be benign or malignant. This was the this right here is what we have over here is the flow cytometry, and as you can see, for the flow cytometry, we have a population of CD5 and CD19 positive cells. These cells here are kappa monoclonal, and as we see, they are also expressing CD23. These cells were CD10 negative. So this is what typically we would see on flow cytometry for a CLL SLL, and another marker that is helpful is CD200, which also shows positivity in CLL. So let's move on to case number 3, which was a 65-year-old male with a retroperitoneal lymph node. So looking at the slide over here, we see that it is mainly a very cellular lymphoid aspirate. At this magnification, we are not able to see exactly the size of the cells, but it seems like there is a mixture of small as well as larger cells. Going on high magnification, we see that most of the lymphocytes here are larger ones. Some of them have a prominent nucleolus, while others have this cytoplasm, which can be like basophilic. There are some smaller lymphocytes in the background. So the pattern here was predominantly a large monomorphic cell pattern. So if you look at the clinical suspicion for this case, it was high. The pattern already said is large monomorphic predominantly. The preliminary diagnosis it is probably a malignant aspirate. Flow cytometry, yes, we should definitely get, as well as a core biopsy. This is what the flow cytometry on it looked like. So we have a population which is right over here, as you can see, on the forward scattered versus the side scatter gate. Now forward scatter means that the size of the cells is larger, while the side scatter is usually refers to the internal complexity of the cell. So the larger the cell, the higher it would be on the forward scatter, and that is what we have here. And then we have these large cells which are positive for CD10 and CD19. They are positive for CD20 and are also kappa restricted. The excisional biopsy on this showed effacement of the lymph node architecture by these medium to large sized atypical lymphocytes, which were all CD20 positive. There was a significant number of T cells interspersed in there, which you can see on the CD3 immunostain that we performed. And probably if you go back to our touch prep or the aspirate, we can see that the smaller lymphocytes probably represented these T cells. So a predominant large cell pattern can be seen in diffuse large B-cell lymphoma and its variants. And if you look to the box which is on the right, we can see the classification according to the WHO. There are many different types of large cell lymphomas in here, and some of them which are important for us include the DLBCL NOS, the T cell histiocyte rich large B cell, we have the EBV associated lymphomas, and then the high grade B cell lymphoma. So other thing that we should remember are the high grade 3 follicular lymphoma, Richter transformation of CLL, the T cell lymphomas, as already mentioned, blastoid mantle cell lymphoma, and some metastatic malignancies, which can present with a discohesive large cell pattern. Moving on. So briefly, we'll talk about the high-grade B-cell lymphomas. This is a new entity which was defined in the new WHO classification. So these are lymphomas which are in between Burkitt and DLBCL. So they usually have a MYC translocation and a BCL2 with a BC with or without BCL6 rearrangements. So the high-grade B-cell lymphomas can also be not otherwise specified. So these are the two main categories under it. Morphologically, they can resemble Burkitt, but a strong BCL2 and a MUM1 is seen with an absence of BCL6. So they are usually, to summarize, positive for CD10, CD20, BCL6, BCL2, and important to exclude a lymphoblastic lymphoma, so we can do a TDT, and important to exclude a blastoid mantle cell, for which we can do a cyclin D1 and a SOX11. These are very aggressive lymphomas and usually have a poor prognosis. Moving on to case 4, which is a 62-year-old male with a soft tissue mass, or it was like probably a lymph node, they were not sure. Once we look at the aspirate, we see that there is a lot of background debris, which looks like some naked nuclei, some necrotic cells, and interspersed in there are these larger singly scattered cells. Going on high magnification, we can see that these cells look lymphoid. Again, in the background, some naked nuclei, some debris. So the clinical suspicion for this case was again high. The pattern here again is monomorphic, mostly large cells that we see. Preliminary diagnosis, malignant. Should we get a flow? Yes. Should we get a core biopsy? Yes. Looking at the biopsy, as you can see, the cells that we see here resemble the cells that we are seeing on the cytopreps, and what we see are these same large lymphoid cells with some cytoplasm. On performing the immunostains, most of these neoplastic cells were CD3 positive, they were CD5 negative, and they were expressing CD7. This sample was sent for flow cytometry, and on flow you can see that again on the forward scatter, these are the larger cells. They were CD3 kind of dim positive and CD7 was bright, while CD4 and CD8, which you can see right over here, were negative. So a double negative is also not normal for T cells. So this was a T cell lymphoma. T-cell lymphomas can be nodal, they can be extranodal. Usually they are rarer than the B-cell lymphomas, around 10% of non-Hodgkin lymphomas in US and Europe. And the way to identify them is usually with aberrant T-cell markers, like there can be loss of CD3, CD5, CD7. And some of the ones that we should be aware of are the AITL or the angioimmunoblastic T cell, the PTCL, NOS, we have the anaplastic large cells, and then the others which are like hepatosplenic, intestinal, and mycosis. T-cell lymphomas do require additional workup. They usually require tissue biopsies, excisional biopsies, and also sometimes TCR or T-cell gene rearrangements are needed to make accurate diagnosis and to classify them. Moving on to case number 5, which is a 26-year-old female with a left cervical lymph node. So over here we have the aspirate, which is again very cellular. But what catches our eye are these big cells in there, which look very pleomorphic, and they have this multinucleate kind of multilobulated appearance. We can appreciate some nucleoli in there. So a very pleomorphic pattern. For this case, again, the clinical suspicion was high. The pattern is here pleomorphic or like a polymorphic pleomorphic pattern. The preliminary diagnosis, malignant. Flow cytometry with the differential that was going on in that we would think about with this kind of a picture, flow cytometry would not really help. And a core biopsy, yes, that would be something that we can perform immunostains on. So a pleomorphic pattern is usually seen in Hodgkin lymphomas, in anaplastic large cell lymphomas. In Hodgkin type Richter transformation, we can have these variants of DLBCL like a T cell histiocyte rich B cell or a primary mediastinal large B cells, the EBV associated lymphoproliferative disorders. Then we can have the peripheral T cell lymphomas and metastatic malignancies. So the important thing here also is the reason these are sometimes difficult, like this case, of course, has a lot of these pleomorphic cells, but sometimes due to sampling issues, there can be paucity of these pleomorphic cells, which can be seen in like a T cell histiocyte rich B cell lymphoma, where it would be very, very difficult to accurately diagnose them just on the basis of a fine needle aspirate, or even sometimes core biopsies would not be enough and you would need a larger excisional biopsy specimen to accurately classify them. So this was actually a very nice cell block on this, and as you can see, there are some EOs which we can appreciate on the cell block. Interestingly, these EOs we could not see on the aspirate, which was strange, but we performed the stains on the cell block, and as you can see, the CD15 and the CD30 is highlighting some of these larger cells. So this was a case of a classic Hodgkin lymphoma. Briefly, to talk about classic Hodgkin lymphomas or Hodgkin lymphomas in general, there are two main subtypes. You have the classic and the nodular lymphocyte predominant. The classic Hodgkin is further subtyped into nodular sclerosis, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. Again, subtyping on FNAs is usually not recommended. Before we move on, I would briefly like to address the Reed-Sternberg cells and the different variants that we can see of these cells. So whenever we think of the Reed-Sternberg cell, we think of the classic binucleate or the owl's eye look. But it is important to keep in mind that they can have different appearances. So we can have the multilobate or the multinucleate form. We can have the lacunar cells, which are seen in nodular sclerosis. We can have the mononuclear variant of the classic Reed-Sternberg cell. So instead of binucleate, it'll just be one single with a prominent nucleolus, and that would be the Hodgkin cell. And lastly, we have the popcorn cells. The popcorn cells are usually seen in NLP, and this is a very nice touch imprint. You usually have these convoluted appearance to the nucleus. So just to keep in mind that Reed-Sternberg cell can have different appearances. This is the last case that I have here. So this is a 45-year-old female with an axillary lymph node. Again, a very discohesive, very cellular aspirate. We have these large cells which have abundant cytoplasm. Some of them have a plasmacytoid appearance and a prominent nucleolus. This is the PAP on the same case. Again, you can see a significant amount of nucleus. One of the things which comes to mind when you think of eccentrically placed nucleus are plasma cell neoplasms. However, it is important to look at the nuclear features as well. And plasma cell neoplasms will have characteristic nuclear findings like a clock, like what we call a clock face nuclear chromatin. Also, the clinical history is very important in addressing these specimens. This patient had a history of melanoma. So the question here was, is it a lymphoma? No. Do we need a sample for flow cytometry? No. So this just highlights that metastatic malignancies are usually more commonly seen in lymph nodes than primary lymphomas. We'll briefly talk about what the current guidelines suggest for lymphoma workup. So we have the NCCN or the National Comprehensive Care Center Network guidelines, which are for Hodgkin lymphoma, which recommend that an incisional or an excisional biopsy is the first thing that we should get if there is a high suspicion of this, a core needle biopsy, and enough material for ancillary studies. Looking at the guidelines for peripheral T-cell lymphomas, B-cell lymphomas, and CLL, SLL, if there is a high suspicion of lymphoma, incisional biopsies are the incisional or excisional biopsies are best. a core needle biopsy. However, in this case, a combination of core needle biopsy or FNA and core needle biopsy, and making sure that we have enough for flow cytometry, for molecular analysis, and for ancillary studies is also good enough for this. This year in January, these laboratory guidelines came from the American Society of Clinical Pathology and the College of American Pathologists for workup of lymphoma in adults. And some points which are pertinent to the cytopathology practice include that there was strong recommendation that FNA cytomorphology alone, without ancillary testing, usually should not be used to definitely diagnose lymphoma. There can be issues because of low sensitivity and low predictive value. Immunophenotyping by flow cytometry or IHC should usually be used in addition to morphology for diagnosis and subclassification of lymphomas. Another excellent article which which was published in the Journal of American Society of Cytopathology. This paper summarized the impact of these guidelines on the cytopathology practice, and it essentially reiterated the same points. We are all aware of the increasing complexity of classifying lymphomas. In some cases, it is not even possible on core biopsies to accurately classify the lymphomas. However, as we move more and more towards minimally invasive techniques for diagnosis, fine needle aspiration, touch prep, and core biopsy together with ancillary studies can still help. Important here is to understand that cytopathologists should at least have some working knowledge of the WHO classification. And this is actually important because you need to have a conversation with the clinician and include the hematopathologist, in fact, get their opinion, and to have like so that we can have an integrated approach to the diagnosis. Again, if you look at the recommendations, we see that surgical biopsy is usually preferred when there is a high suspicion for Hodgkin lymphoma. Excisional or core biopsies should be obtained when there is a high suspicion of lymphoma. However, a touch prep or an FNA can help at that time to determine the adequacy and to at least have a prelim diagnosis. Again, the role of ancillary studies like flow cytometry and immunohistochemistry is very important. Moving towards the future trends, so there has been a proposal for standardization of lymph node fine needle aspirations, and this system is named as the Sydney system. This allows categorization of lymph node fine needle aspiration diagnoses. It provides 5 different diagnostic categories and also provides a management algorithm. This is still a work in progress. There have been some preliminary studies which have looked at applying this system to the diagnosis of lymph node FNAs. So we do look forward to working on this system and once it comes out to looking at validating it. As with other reporting systems, we must remember that standardization does help in improving the clarity and the diagnostic value of our reports. So these are some things that we have to keep an eye out for in the future. Thank you very much. I would like to acknowledge Dr. Vlad Shpanka, who's my excellent cytopathology fellow, for the pictures that he helped me with, and the EPAC team and my mentors at Loyola Cytopath and Cleveland Clinic. Thank you very much.